Welcome
Hi,
to
everyone.
Podcast with the Professors.
How
Huh?
are you?
You know
I'm
who we
Professor
are.
Lopes.
I'm Dr. Hurlbert, and we're here talking about our time as nurses.
Yeah, we've been a nurse for quite some time.
And honestly, you've been a nurse not quite as long as me.
I've been a nurse for a decade now.
3 decades, 3.5 decades.
Mm,
So we got a lot of stories, and then
we
many of
do.
you have heard some stories, but we just wanted to kind of narrow it down and talk about some things. Kind of sum up the last few weeks here in class. A lot of this stuff is a long-awaited roundup of information. Um, but it's all about the stories. I know in terms of stories, I myself, as a laboring mom, I ended up having a C-section. Um, is that it has its own issues. It's still having a baby though, right? And there's
It
some
is
differences in term. I mean, I know we talked about it's all about the bleeding and whatnot. Um, is it the same whether no matter how you deliver in terms of bleeding?
definitely not. And I could tell you, I've had both vaginal and C-section, so bleeding's very different. I usually find too with patients that with C-sections, the bleeding's a little bit lighter. The
Okay.
uterus didn't do as much work is usually how I like to explain it to our
Okay.
moms.
Mhm.
And plus the doctors do a lot of that work of like getting most of that uterus and placenta and everything out. So
All right. All right. Would in terms of like a postpartum hemorrhage, is it the same like the way we would quantify the blood loss the same?
no, no, no. So vaginal delivery is usually about 500 mLs or more,
Would be
whereas
considered a
a
postpartum hemorrhage?
postpartum
All
hemorrhage.
right. Same
And
for C-section?
no, so C-section is going to be 1,000. And so usually I think about like water bottles. So if you look at this, just your regular water bottle, this has
Mm-hmm.
about 500 mLs of water. So all you need to do is lose about one of these of blood. And that's considered a hemorrhage for vaginal delivery.
Okay.
You put two together, you're now at 1,000. That's about a hemorrhage for a C-section, mom.
That doesn't seem like a whole lot in the scheme of things.
You're right, it doesn't.
Do we collect it like in a bottle? We measure, I know at the hospital I work at, we weigh it.
We do as well,
Mhm.
yeah. So usually the doctors will look at it, what's in their suction canisters, if it's a C-section mom.
Actual volume.
Yeah,
Okay.
looking at the actual volume. Also, there's something that collects it for vaginal deliveries. They look
Mm-hmm.
at that. And then after delivery, we're looking at how much mom loses and by weighing her pads. And we are doing that um, very closely in that first hour and two.
Yeah. Is that when it's going to happen?
No, no, you can hemorrhage at any point. So your postpartum period isn't just the first like hour recovery. Your postpartum phase lasts up to the first 6 weeks
Wow.
after
So
having a baby.
you could have a postpartum hemorrhage like like 2 days after delivery?
You can, yeah.
Okie dokie. Let's talk a little bit more about the fundus, bleeding in general.
Bleeding, yeah.
What um what do you do for a postpartum hemorrhage? What do you do for that? Just pray that they stop bleeding?
Praying helps. Praying would probably help, but as the nurse, first thing you're
Mhm.
gonna do is you are going to massage that fundus.
All right.
There's nothing fun
All right.
about it. I don't know why it's called a fundus. I think every
Well, you know
single mom
what?
hates this part
I
of the
did make a
exam.
video years ago with some of my students. We called it "We Put the Fun in Fundus."
Yeah, I'd like to see the patient that's hemorrhaging that says
That's
that's
fun.
fun. Because you're in there, you're massaging. That's
All
the
right. So
first thing you're gonna do.
if the bleeding is coming from I know my students heard old and tired uterus, like a just so it's a tone issue, like the uterus isn't contracting down, right?
Tone issue,
All
yeah.
right, all right. So we got some we see a bunch of bleeding and we assess. the fundus.
Assess the funds. That's the first thing you can do. That is CPR for a postpartum
All
patient.
right, so the first thing you do is check the fundus.
Check the fundus.
And what are you going to find?
Well, it's probably going to be boggy. You're not
Boggy.
going to feel something nice and hard, which would be firm. That's what we want.
So
But if she's bleeding,
it's going to be squishy,
squishy, soft.
squishy, boggy.
Yeah.
Okay. And if it's squishy, boggy, you massage it.
You're massaging there. You're not massaging like this, right? Not
So
the
it's
type
not
of
a day at
massage
the
you'd
spa
want.
kind of
No, definitely not a
massage.
day at the spa. No, you got to get in there, get your hand nice and deep. Massaging like
Yeah.
that.
Yeah. All right. What else can we do?
There's medications
Oh,
you can also give.
all right. I am thinking first line medication, I think, is oxytocin or Pitocin.
Yeah, that's correct. First line is Pitocin.
You know what? My students know, and now your students may know soon. My favorite hormone is oxytocin.
Yeah, I guess.
You're like, lady's crazy.
Well, maybe.
My favorite hormone is oxytocin for a couple of reasons. One, it it's a love hormone. Call it the love hormone. Oxy oxytocin helps with like milk letdown for
It does.
for
It does,
breastfeeding.
yeah.
It also helps to contract the uterus.
It does, which is what we need to prevent a postpartum hemorrhage.
So we might give them the manufactured hormone.
Yeah.
In the form of Pitocin.
We do.
Okay.
And it's pretty standard that most patients are already getting that through their IV. We just might give them a little bit more of the love hormone.
The love hormone. Is there any other meds that we might give?
Yeah, so I would definitely suggest Methergen.
Methergen. Can we just give that to anyone?
No.
No.
So you definitely want to assess your patient's vitals. You should be assessing your patient's vitals regardless, because you're going to notice some changes in their vitals. Sometimes the patients might be a little bit tachycardic. Sometimes they have a little bit of an elevated temperature after delivery or the first 24 hours. Totally normal. We don't get too alarmed with that. However, I'm really going to be paying attention to their blood pressure. That's
Okay.
one thing you want to check before you give Methergen.
So you give it contraindication is high blood pressure, right?
High blood pressure, because that's what Methergen's going to do. It's going to bring up that blood pressure.
Bring up the blood
I don't
pressure.
want to make it higher for someone who
So if it's
already has
already
an
high.
elevated
All right,
blood
so if I'm
pressure.
calling the provider and I'm saying, this patient's bleeding, blah, 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 I should know what the blood pressure
You
is.
should.
Okay.
You should. And if they say give Methergen, you don't do it if your patient has an elevated blood pressure. You can consider an alternative, which would probably be Hemabate.
Hemabate's a good one.
Hemabate.
There's a contraindication to that too, though.
Yeah, asthmatics.
Yeah.
So you got to know your patient's history.
Yeah. And you need to share that history if it's a provider that's not familiar.
Yeah.
All right. Hemabate. Carboprost, I think that's the name of that,
correct.
right?
Yeah.
Methergen, the generic name is methylergonavine malate.
Something very fancy like
Fancy.
that.
Yeah. The fancy name.
You know, I still don't understand why they don't just call medications like hemorrhage stop. Wouldn't that be a better name? Hemorrhage stop.
Hem stop.
Yeah, right.
Ooh, maybe
we should start that.
Maybe we can.
And then we don't have to teach the rest of the semester.
Hem stop.
All right. We'll get a patent on it.
Yeah.
I like it.
There's some other fundus things. Because it's all about the fundus. Say, maybe I go to do my postpartum assessment. And one of the things is obviously checking the fundus, right? The U bubble. And I find it should maybe like right after birth, like the first 12 hours or so after birth, I should probably find it around the belly button, right?
Correct.
All right. Right in the middle of the belly, right in the middle and at the belly button.
Yeah, because that's where your uterus sits. When you're not pregnant, it sits in the middle of your body, ideally.
Okay. So I go to feel on my patient and I can't find it right there. I actually find it way above her belly button and like over to her right side. That's a pushed around uterus.
That is.
What's pushing it around?
Chances are she hasn't voided. That
Full
full bladder.
bladder, full bladder.
Yeah.
All right, all right. I'm hearing that we need to cut to one of our sponsors.
Yeah. So this podcast is brought to you guys by Bubbles Inc.
Bubbles
There's
Inc.
nothing more fun than bubbles, especially as an OB nurse. We love bubbles.
I don't see any bubbles.
Of course. There we go. There's nothing more fun than bubbles.
Nothing more. Look at this. See,
And
you
as
did
OB
this in class.
nurses, we love bubble. We love bubble because that is our assessment as postpartum nurses.
Very nice. Very nice.
Mhm.
Thank you to our sponsors who keep us fed and keep this podcast going.
Yeah.
Thank you, Bubbles Inc. So the fundus is bubble would be the U,
The
bubble, right?
uterus, yeah.
Breast uterus. All right.
Breast.
So feel the fundus. One of the other things we're looking at is lochia. It's all about that lochia, right?
Lochia, yeah. I like
So,
that word. You like that word? Lochia.
lochia,
Yeah. I kind of wish though it was more pronounced with like that Italian accent.
lochia.
Yeah.
Yeah.
Lochia.
Lochia.
Yeah.
Lochia.
Right?
Yeah, it's not.
It's
So I don't think. Yeah, it's not
I mean,
nearly
I
as
guess it's
exotic.
something not that pretty, but like lochia.
Lochia.
I mean, the first lochia is usually rubra, like pizza sauce, that red color.
You've just ruined pizza sauce for me. Thank you
I
so
think
much.
it's really difficult to ruin food once you're a nurse, especially an OB nurse.
My students know I've ruined already several. I have a couple more foods I'm gonna ruin
Oh,
just this very podcast.
then there you go. You have
So we got Lochia rubra.
yeah,
All right, that's the first bleeding.
that's the
you do.
first
That's a
bleeding.
darker red blood, right?
Dark red blood first 3
All right.
days usually. So
First
it's
3
usually
days?
about first
Okay.
3 to 4 days. That's usually what you're seeing the patients have in the hospital.
Okay.
And then it's
And
gonna
then the bleeding
transition.
stops?
Oh no, don't they wish? Wouldn't that be nice? But you know, women just gotta have it all. So the bleeding is going to continue. I mean, you can have discharge up to the 6 weeks postpartum. That's why that postpartum period's up to that 6 weeks after having the
I
baby.
see, I see.
So after
So then
rubra,
it gets, okay, rubra, then what?
serosa.
Serosa, and that's, you said day 3?
About day 4 to 10, usually you
All
see
right.
serosa, and that's more of a pinkish brown color.
Okay.
So I tell a lot of women it's almost like having that heavy period, and now you're approaching the end of your period, that pinkish brown color.
Okay. So it lightens in color and amount, if I'm not
And
mistaken.
amount, it should be,
All
yes. You
right.
don't want to see an increase in bleeding.
All right. So it gets lighter in color and amount. Lochia rubra, Lochia serosa, and then it's done?
And then you got Lochia alba.
Lochia alba.
Yeah.
All right, and that's just kind of whitish. You think it's just like a little
Yeah.
discharge.
Whitish yellow color
Oh, that's
sometimes.
pleasant.
But there shouldn't be an odor. So that's the
No
biggest thing.
odor.
No
All right.
odor. Because sometimes people get it confused with like a yeast infection, but it's not.
Okay, it's just
Almost that whitish
the rest of
color.
the slough off.
Yeah.
Just for a minute, let's talk about odor though. So signs and symptoms of infection, say like with a C-section. You
Yeah.
see like from the incision itself, we might see some drainage from it. Like
Drainage.
pussy
Yeah.
kind of drainage.
Yeah, that's not good.
Good times.
I'm hoping not
Good
to see
times.
that.
No. That Rita, REEDA, redness, ecchymosis, edema, drainage, approximation.
Yeah.
All right, so something's gonna be off in those elements.
Yeah.
Ugh. We're gonna be looking for other signs and symptoms of infection, which could be what? Fever, overall aches
Okay.
and pains, you feel lousy,
Aches and pains,
right? That
yeah.
would mean that maybe it's not just a localized infection, it's like
Systemic.
systemic infection.
Yeah.
Ooh,
Yeah.
That's
So you
that's
see that,
rough.
you better assess your patient.
That's rough. That's rough. So, okay, let's get back to the bleeding. Sorry, I just had
No,
stepped
that's
off on
fine.
that.
Hey, we gotta talk about it. You still gotta assess your patient. You gotta, head to toe.
Right, head to toe. So bleeding. The first question I ask, I don't know about you, is when did you last change your pad?
Yeah, that makes a big difference in
Right?
your
Like if
assessment.
am I looking at 15 minutes worth of bleeding or am I looking at 3 hours worth of bleeding?
Absolutely. I mean, I've
Right?
had patients that can go all night without changing the pad.
Right.
Well,
I
my
tell them
God,
not to.
me neither, because I mean,
Mm.
you got to think
Even if
proper
it doesn't
hygiene.
need to be changed, I say change it because if you just want a fresh, clean start.
Like, it just makes you feel better, I would
Mm,
think. Yeah,
okay.
sometimes I have patients. So it's important to know how
Mhm.
long they've been sitting on that pad because how long has that bleeding been there? And especially when you're looking at the amount. Is it
Yeah.
scant? Is it light? Is it moderate? Is it heavy? So you're
So
looking
in
for
that lighten amount and color. So as time goes on, it lightens in
should
both. Okay.
lighten in both.
So 4 days, say 3 days postpartum, I go to check the fundus. Am I finding it still right at the belly button?
No, no, no. It should be
No, she
going down.
says,
Should be going down. I mean, it's got to go back to where it came from
which is in the pelvis.
in the pelvis.
So
It
it
should be
shrinks down. Boom,
going
boom, boom,
down,
boom,
down,
boom.
down every day, about a centimeter or finger breadth. I guess it depends on if you want to use that fancy terminology.
So 1 to 2 finger breaths or centimeters a day descending in the abdomen.
Yes. But when you're looking at a day, you got to think about hours. When did a woman deliver? Think about that because it's a
Oh,
24-hour period. Because if she delivered at 11 p.m. at night and you're assessing her fundus at 8 a.m.,
so
that's been less than
that's
12
not even
hours. So
12
she still
hours. All
should be
right.
firm at you, at the
At the
umbilicus,
umbilicus.
right?
That
But
makes sense.
if it's 11 p.m. at night, or she delivered 11 a.m. and you're doing your assessment at 12 p.m. the next day, then she should be ideally
Oh, that
a
makes sense.
centimeter below.
You know what? Your professor is hugely smart. Hugely smart.
I went to college.
Yeah, that's nice to hear. So bleeding, turns out bleeding is the #1 cause of maternal mortality worldwide.
Yes.
A good many postpartum hemorrhage could be prevented.
Yeah. Up to
Yeah,
90%.
90%.
90. 90%
So we got to be ready
of
for it, right?
maternal deaths from postpartum hemorrhage are preventable.
Wow. I know my class, I know we talked about breastfeeding racial inequities, but let me tell you, there's racial inequities when it comes to postpartum hemorrhage too. So we need to be paying attention to all our patients no matter what. There's different sources of bleeding. And I thought the book and just smart people that I surround myself with, that one over there. We talk about the 4 T's. I know we talked about it in my class. I bet you talked about it in
I
yours
might
too.
have mentioned it. Maybe if they're lucky.
What do we got? Tone.
Tone, which is your number one. You got
That's
tone.
like
Number
uterine
one cause.
atony.
Yeah, uterine
That's the
atony.
boggy
Everyone knows
uterus.
tone.
In my class, the old and tired uterus. All right. Uh, trauma.
Trauma. Another
That's
one.
like
Yeah.
tissue trauma.
It's tissue trauma. Yeah. So that's where we're gonna cover like the E on our bubble here.
Okay. All right. So
So you have your
trauma
trauma.
in the down belows.
Yeah.
Yeah. All right. We have tissue.
Two. So usually you're seeing that with like retained placenta.
Okay.
Yeah, so usually
The
you're gonna
confused
have,
uterus.
yeah. Um, one of the other things is usually traction too, where the
Oh, yeah.
umbilical
Oh,
cord could
that's
be,
the fifth
yeah, the
thing.
fifth one. But it kind of ties in a lot of times with that retained placenta
Yeah.
because after mom delivers a baby, that placenta also needs to be delivered. But sometimes providers might be a little bit impatient pulling at that umbilical
Yes,
cord.
yes.
And
I tap him on the shoulder and look at my watch. It's only been 5 minutes.
yeah, and you have up to 30 minutes
30 minutes. That's stage 3. We'll get into that
later on.
in a couple weeks. Okay, so we got tone, trauma, tissue attraction,
Yeah,
and then the last one,
thrombin.
thrombin.
So that's usually going to be related to a mom that has some form of like a coagulation disorder.
Mhm.
So TTP, what else? DIC, von Willebrand. So usually
So
you know that
sometimes,
in your mom's history.
sometimes, not always though. Not always. Sometimes this is the first time their body's been tested at such a rate. But anyways, okay. So it's going to be one of those 4 T's that's going to lead to postpartum hemorrhage.
Yeah.
Interesting.
No.
I think I'm done talking about bleeding.
Bleeding, you're
I think
over.
I'm done talking about it, but I want to go back to the beginning of this bubble business. Breasts.
Okay.
The breasts.
Yeah, breasts are
Yeah.
important.
Yeah, so
And you
let's talk
never
about
really
the,
look at them until you're in
well,
old
I mean,
years.
some might, some people might.
That's
I
true.
honestly, there's a whole lot to breastfeeding. Like, we hear about, or we might see people breastfeeding and they seem to have it all under control and stuff, but new mom, new baby, neither of them have done it before.
No, it's
So it takes a
hard.
lot of support. It takes
It's
a
a
lot of
lot
support, a lot
hard.
of assistance from staff. We try to get the whole family involved in the whole process. We need to consider cultural considerations. We
Absolutely.
need to provide privacy. We need to seek permission before like touching our patients, that sort of thing. I'd also say that if you can breastfeed the first 2 weeks, you can survive breastfeeding for the first 2 weeks. You can breastfeed for 2 years. It's the getting to know, yeah, trying to get the baby to figure out how to do it. Lots of things can happen. Engorgement. What engorgement? Oh. And
Encouragement.
as the milk is coming in, the baby's trying to figure out, how do I know the baby got enough?
Yeah, no, those are really good questions. And I think that's probably one of the more common questions moms ask
Every
because when
every
the
every
baby's
shift.
at the breast, you have no idea how much that baby's really getting.
Yeah.
I usually like to reassure parents that we're weighing the baby. They should be making wet diapers, usually by the end of the first week, like 6 to 12 wet diapers.
Yeah, six to
Mm, You
10,
know,
6 to 12 wet diapers a day. What goes in has to come out, right?
exactly.
Although I will say babies, and we'll talk about this a little bit more when we get more into newborns, but babies do lose a little weight.
Yeah, totally
Uh,
expected. They should, right? That
all
waterway,
that
especially
water
the first
weight,
few
they're
days.
pooping and peeing a whole lot more than
Yeah.
they're taking in. All right, so they can lose up to like 10% of their body weight
Yeah.
before we get too concerned. I
Yeah.
mean, we don't want it to go over
Yeah.
10%. All right, but breastfeeding, man. So as they're establishing their milk supply, figuring it all out, I just say let's just offer and try to breastfeed at least every 2 to 3 hours.
Yep.
Obviously, if the
Absolutely.
baby wants to do it more, the baby does it more,
Yeah.
cluster feeding and whatnot. But every 2 to 3
Should be.
hours,
Should be. And you got
wake
to
them
wake them
up, get
up.
them going.
Even at nighttime, you got to wake them up. Babies need to eat around the clock.
Every 2 to 3 hours.
Yes.
That's good to know.
Imagine if you could eat every 2 to 3 hours
Sometimes
and then
I
you'd
do.
lose some weight.
Oh, sounds like a pretty
I
cool
mean, I
thing.
practically eat every 2 to 3 hours, so
I
maybe I
was
am a
gonna
baby. I
say.
don't even know. But yeah, no, it's normal.
Mhm.
And so yeah, a lot of encouragement, a lot of
Yeah.
education there, especially because it's so common for moms to be like, they're not getting anything, I'm not producing milk. And it's so common, but there's also colostrum. A lot of educations to go into that. So many people don't know what colostrum is.
Colostrum's pretty important.
Yeah,
A lot of
liquid gold.
liquid gold. We'll
And
talk about
gold
that.
is like a big thing.
The gold is, yeah. Um, Valuable. It's small in volume, but large
And
in nutrients.
nutrients,
Antibodies. They can have
antibodies, yeah,
passive
passive immunity.
immunity
Yep.
through that. That's really, and I know I was telling my class, there's been studies done on if the baby is suffering from some sort of like virus or something like that, and they continue to breastfeed, mom's body senses the virus and will send antibodies through the breast milk. It's a pretty sophisticated system. It's a supply demand system as well. So if you demand it, they should supply it, right? So frequent feeding should get the milk flowing. With engorgement, you want to try to get that milk
Yeah.
out. What about mastitis, though? Tell me a little bit about
Mastitis,
mastitis. How do I
same
know the difference
thing.
between engorgement and mastitis?
Yeah, so engorgement, usually moms feel that like discomfort as their breasts are filling, especially as they're getting to that transition milk from the
Yeah, yeah,
colostrum.
yeah,
Your mastitis is going to be an infection though. And so
yeah.
usually your moms have like this painful sore area on the breast. Could be both, could just be one breast. And they also feel like really tired, really weak. A lot of moms say they feel like they have the flu. It's like the
Okay.
biggest thing. So they have an elevated
Right. Well,
temperature too.
I guess that ruins breastfeeding,
No,
right?
no, no,
They have to
no, it
stop
doesn't.
breastfeeding.
I know so many people think that, and so many moms will actually stop breastfeeding due to mastitis, but they
Mhm.
should actually continue
They
to
should continue.
breastfeed.
Yeah. Last thing you want is get engorged on top of
Yes,
mastitis.
because a lot of times that happens because the milk is just sitting there in the breast. There might be a blocked
Hmm.
duct.
Hmm.
Even mastitis too, if they have like a cracked nipple or something, baby had a poor latch, we'll see that.
Is that how they got infected?
A lot of times it is.
So check those nipples.
Check those
It's a
nipples are
skin
important.
integrity issue, really, at the
It is.
bottom line.
But yeah, definitely have your moms continue to breastfeed. They
Okay.
shouldn't stop.
And one other thing I want to talk about with breastfeeding, I have a lot of patients, they've had a couple of babies and they're breastfeeding. They're like, man, when I breastfeed, I really get crampy.
Yeah.
Yeah, that's my favorite hormone at play. So the oxytocin, which is helps with milk letdown, it certainly when they're breastfeeding increases the oxytocin circulating around. Oxytocin also makes a uterus contract.
It's one of those things like it sucks for the mom, but also it's a good thing because it's helping your body do what it should be doing. So it's also a really good indicator if you feel those cramps. I always tell moms like breastfeeding is working. You're doing well, baby's doing good because you're having those cramps.
I told a story in my class. I delivered a baby in the
You delivered a baby.
I did several. I delivered a baby in the doctor's office, not in the hospital, which as I was saying, I was the only one thrilled about it. It had been a while since I'd been in on delivery. It was not my intent to bring the patient to the office to deliver there, but she fooled me. I said, "Why don't you stop in the office? Bring your stuff to go to the hospital, but I want to make sure that you're in labor first. Come to the office because the nurses on the unit would get really pissed off if we just sent all the patients for triage to the hospital."
I'm going to vouch for that. That is
Yeah,
true.
yeah. So I brought her to the office to assess her there to see if she was in labor. In fact, she was quite advanced in labor to the point that I didn't want to have her deliver in the ambulance on the way to the hospital. So I chose to deliver her in the office, which was great fun for me and not for anyone else. So I was setting it up and I was trying to make it a nice, calm environment and a good experience for the couple who was already a little, overwhelmed. And I said, "Are you going to breastfeed? Are you going to bottle feed?" They're like, "Oh, we want to breastfeed." I said, "Oh, okay." And so, baby's born, baby does fine. I'm like, "Okay, let's start breastfeeding." And I'm like trying to help the baby to the breast and the staff, the tech, the MAs and stuff were in the hallway like, "How about you get her in the ambulance and get her out of here?" You know what I mean? Everyone was trying to like, just, I know you're trying to be nice, but let's get this patient out of here. And I'm, "Oh, let's breastfeed." And I was like helping her breastfeed. And they really were like getting impatient with me. Like, we really should get this patient to the hospital. Um, and the placenta delivers. I'm in there helping her breastfeed and do all these things. Made sure she was stable, made sure the baby had a little something. And afterwards, they're like, "Why didn't you just send her to, on the ambulance was there. You should have just sent her to the hospital." And I said, I was trying to prevent a postpartum hemorrhage. I didn't have any Pitocin in the doctor's office, so I had to use the body's natural oxytocin.
That is smart.
So I, in my wisdom of many years on the job, decided to make it a nice experience or make it seem like I was making it a nice experience for the parents, which what I was actually doing was giving her a dose of oxytocin or Pitocin to prevent a postpartum hemorrhage. So that's why I was doing all of that. Needless to say, the baby liked it. Mom did not hemorrhage. She was stabilized, put on an ambulance, and sent to the
You
hospital.
saved her life.
Saved her life.
That's
So
good.
that oxytocin is, and some patients actually respond better to their natural oxytocin. So you might be given Metrogen, Hemabate, doing all those different things for a postpartum hemorrhage. If they are physically stable enough, getting the baby to breastfeed might also help some increased bleeding.
That's smart. Your
Because
professor is also very smart.
there it is, old and wise, as I say. Um, then some other things I want to talk about. It's kind of bleeding related, but hematoma, perineal
Ugh.
hematoma. Have you seen them? Have you ever seen them?
Yeah, I did. I actually once had a patient. I was taking care of her and I had her on day 3,
Mm-hmm. Mm.
and she had this huge blue mass when I assessed her perineum.
She wasn't complaining?
She was, but the thorough assessment was only done, I guess, when I had her.
I
She ended
see.
up having, I once I saw that, I called the doctor right away. That's, you know, not the best thing to see. I called the provider, he came to the bedside. Within an hour, she was in the OR, and she had almost as much bleeding in there as would have been a hemorrhage.
Yeah. So there's a couple things to consider. First of all, I'm surprised that this hematoma could have gone so unnoticed because the patients I've had with hematomas are very anxious
Yeah,
and they're very
uncomfortable.
squirmy and they're very, very uncomfortable. A
Yeah.
stinging, burning pressure pain that makes them,
I feel like it was missed because she had an episiotomy. And you see that so many times with patients that have episiotomies or a
okay.
fourth degree
Mhm.
too. And so they're already in so much pain, and we're already doing all the interventions of medicating them, giving them ice packs, we're giving them the sitz bath, the waffle pillow to sit on.
Got all those things, yet
All
they could
these
have this
things.
amount of blood. They could have whatever total behind that hematoma. We're seeing the tip of the iceberg
Yeah.
with a little bluish bulge, like at the perineum. They could literally have a postpartum hemorrhage amount of blood, or add that to what they've already been bleeding. It can add to a postpartum hemorrhage just with the blood from a hematoma. Is there anything we would do, or is it just call the provider?
Call the provider.
Call
There's
the
nothing I
provider.
can do.
Yeesh.
Nor do I want to. I don't want to be the one
Oh.
handling that.
So you mentioned all those different things with the episiotomy.
Yeah.
Um,
That's our E in bubble at the end.
bubble E,
Bubble
bubble
E. Bubble.
E, L
Yeah.
E.
E.
Episiotomy. That would also
Mhm.
be like an incision too, I suppose.
Yeah, I
Stitch
usually
is
say
very different.
laceration. I think it's just because bubbles are so cool. Thank you to our sponsor, by the way. You're awesome. But episiotomies, they don't happen as often, but when they do,
They do. So we're gonna probably do all those things. The topicals. My doctors at the hospital I work at, my doctors, like they're mine.
you can
Um,
own them. You're right.
um, they give Colace. They
Yeah.
give a stool softener.
Yeah, you have to. Because
Oh,
it's
she
in
says we
you
have.
have to. I mean, think about what these women have experienced, the trauma.
So I've never, in my 35 years, I've never seen anyone pop a stitch by pooping. But why test it? Why test it, right?
Yeah, I know.
Poop,
Exactly.
poop pop. We
And
don't want it. We don't
they're
want it.
so like scared, they're
Yeah.
hesitant, then they don't want to go to the bathroom. And so it's just better that way. Might as well make them comfortable. They've already gone through so much.
So we're gonna do all those things for comfort. Ice in the first 24 hours. Sitz bath is
It's
great.
bad.
It's great, but it helps comfort bubbles, she says. It promotes circulation and healing.
Imagine if a sitz bath was just like this.
Bubbles like that. My gosh.
Yeah.
So that's cool.
Yeah.
Um, it, have you ever watched a program like Law and Order SVU, we'll say?
A
A
program.
program, yeah.
A
Because I'm
show.
old.
A show.
My
Okay.
show. You
Yes.
watched the
Have I
show,
ever
your
watched
show.
television?
Okay,
Okay.
whatever. And they've done an autopsy on like a person they have no idea who they are, and they're trying to figure out who the dead person is and like where they came from or whatever. And part of the report is she's had at least one child. I always just be like, how do they know? Like, how do they know? You know how they know?
Cervix.
The cervix. The
Cervix
cervix
changes.
actually changes appearance if you were looking at it.
Yeah.
Um,
I'm gonna use a mint over
okay.
here.
Well, nothing like ruining a mint for me.
All right, though. I told you, as a nurse, if you're a real nurse, you can literally see food the same
All
way.
right.
So, this is how your cervix usually is. Okay,
If you can
nice
sit.
circle closed before you have babies.
Okay.
Think of mint. Okay, and then it becomes like, what do we
I
have
don't really
here?
have
You don't have
anything.
anything. Okay, well, let's use a candy bar, a slit. Okay, so we go from a nice
Nice
round
round
circle
opening
to this
to a
slit.
slit.
That's what happens. So yeah, that is how
So
you
the
can
medical
tell.
examiner, I think I might have one of these too.
Yeah, might as
Medical
well.
examiner, it didn't ruin this min
It
for me.
shouldn't.
Medical examiner sees the cervix looking like the opening looking like a slit. They know that a baby had passed through that cervix at least once
Yep.
before. So that's how, you're welcome. So if you're ever watching a program on television
Show.
and somebody asks you, how the heck do they know they've had a baby? It's because of the cervix.
I'm sure that's going to be the question that all the students get asked when they're watching a show.
Hey,
How do they know?
oh, you're a nurse. Can you look at this rash? Oh, you're a nurse. How do they know this dead lady had a baby? I don't know. It might come up.
You know what? Maybe they can use that as like an icebreaker when they're making new friends.
Hey, why
Did you
not?
know
That's
how
I
you can
do.
tell?
Probably why I don't have any friends.
I'm your friend.
Thank you. So anyways, back to postpartum, just a little bit more postpartum. Um, you kind of mentioned this a little bit. I just want to make it clear, the body has gone through quite a bit naturally.
Mhm.
Um, and I know vital signs remain fairly stable, but did you say you said something about temperature? Something about the temperature.
Yeah, temperature can be a little bit on the
So they could have a fever?
no, not fever, but like almost like a low grade fever, like high 99s. That's normal in the first 24 hours,
All right, their
especially.
body's heated up. Body's
Oh,
heated
yeah.
up. As long as they don't have any other signs and symptoms of infection,
Exactly. So you're
it's
looking
just
at
their
their
body's
decision,
natural
everything.
defense.
Yeah.
The warriors are coming out
Yeah.
because a lot has happened.
Yeah.
All right. Um, I know that a patient is definitely more at risk for like blood clots during the pregnancy and postpartum, even more so. Our
Mhm.
body coagulation factors, PT, and all the business, all the coagulation factors are increased because we want blood to clot in certain places, but it's not specific just to that placenta site. So I need for you all as nurses, and future nurses to know the signs and symptoms of DVT or of thrombophlebitis. And what's the biggest problem with a thrombophlebitis? Possibly, or DVT, in my opinion, is if that clot decides to dislodge.
You're
Where's it
gonna
headed?
probably the lungs.
The lungs.
And I don't think that's where I'd want that clot to
I
go.
do not want a
That is
clot.
not paradise for a clot. I think they
That's
see it
not.
as that. But the
Eek.
patient's going to be disappointed. They're going to be short of breath, have chest pain.
All right. So pulmonary embolus.
Yeah.
It doesn't matter if they just had a baby or if they're a 90-year-old man. Know the signs and symptoms of pulmonary embolus in your patient. How's that for you? A little
Yeah.
advice from this little gal.
Yep.
Um, two other points for postpartum that I wanna spend some time on. I know I did in class, but reiterate. Um, biggest challenge we have, I think, other than like saving their life from postpartum hemorrhage.
Yeah. Once they're stable,
Once they're
just
stable,
kidding.
we got to get them ready for discharge. We got to make sure they're going home knowing how to safely take care of themselves and their newborn baby, right?
Mm.
Educate, educate, educate. What's the number one challenge of educating our patient, our birthing parent? Guess what? Taking in phase.
Yeah.
That first adaptation, psychosocial or whatever adaptation of the birthing parent is the taking in phase. Taking in phase is kind of a passive role. They're a little self-centered, a little distracted. They need to like talk about the birth
Yep.
experience. They're very,
Yeah.
It's not the
They will
best.
literally be like, "Do you want to know about my delivery?" Like, I was present. I
Mm.
don't think I
Ah.
need to know about your delivery,
But they have
but
to like
sure.
process it through. And it's not that they're being, not that they're not going to be good parents. It's not that there's something abnormal about what they're doing. That's what we see. It's actually the normal progression of the adaptation
Oh,
of a birthing parent is that passive passive role. They want to be taken care of and they want to talk about it.
yeah. And then
Not a
they,
great time to take in a bunch of new information.
yeah.
All the more reason to um, educate every possible opportunity to do so, to hear it so they hear it more than once, and to involve other family members in the education too.
Yeah.
Because they're not in the taking in phase. So that's
No.
good.
But eventually your moms get into that taking hold phase where they're really into
They're
taking care
home
of the
by then.
baby. Yeah, sometimes it happens. So there's been moms, sometimes they skip over it. Maybe if it's like your 10th kid, I don't know,
Mhm.
but they skip over it. But when they're in that
Usually they're
taking
like,
hold
okay,
thing, they take in that information, they
maybe
learn.
so, but they're like, okay, I'm ready. And they're literally on the way out the door. Not a
Yeah.
anyway,
No.
so that passive role, pretty common,
Yeah.
taking in phase, and that's our biggest challenge. Another big challenge and something that I hold near and dear to my heart is postpartum affective disorders. And we have
Yeah.
some like the continuum or the spectrum of postpartum affective occurrences. The first, very normal, 80% of people experience little postpartum blues.
Yeah, totally normal. Baby
Totally normal.
blues.
The baby blues. We're talking,
Baby
I
blue.
I kind of liken it to extreme PMS. They're laughing one minute, crying the next. That's fatigue, fear, anxiety, hormone shifts.
Yeah, it's that huge drop in their hormones, and they
Mhm.
just are moody and very sensitive over
Okay.
everything you say and how you ask things. I once
So
had a
the
patient crying over how cute her baby's ears were.
Okay. All right. See,
Yeah, I
so
told her students.
that's baby blues. A little letdown feeling. Have you ever been planning a big trip? The trip is over, and now you're like, oh, now what? Wedding, you guys are kind of on the young side, but like a big event in your life that you've been like so focused on, and then it happens, and then you feel afterwards just kind of let down after it. So that is could be part of this as well. It doesn't mean that you're a bad parent. It just is the letdown.
Yeah,
It's supposed
okay.
those baby blues, pretty common.
Very common.
How do you
But
know the difference between baby blues and postpartum depression?
that's a good question, and that's something we need to make sure we're educating our moms on
Ah,
because 20% of moms with baby blues are going to develop postpartum depression. And it's usually seen after 2 weeks. So baby
okay.
blues first 10 to 14 days, totally
Normal?
normal.
Okay.
After that, though, after the 2 week mark, you're really down, sad, don't want to take care of yourself or the baby. I usually tell my moms that could be the postpartum depression, and that
Okay.
needs an intervention. Like you need to see your provider.
So there's something you have to do about you do have it's not going to just go away
It doesn't
on
go
its
away,
own.
and it's postpartum depression. So this is happening in that postpartum phase.
Okay.
Doesn't mean that you now have depression for the rest of your life, but it's one of those things that
Yeah.
we definitely want to make sure you are seen and taken care of.
I heard that it can develop or rear its ugly head, or maybe just when the birthing parent is finally willing to admit it, perhaps in the first year after birth.
Yeah,
Yeah.
they can.
The next dial on the needle on the dial, if you will, is postpartum psychosis.
Yeah, and that's not
That's
good.
I've had one patient full-blown postpartum psychosis. She thought she was the Blessed Virgin Mary. She was brought to the
Oh,
hospital. Her husband brought her to the hospital. They sent her up to OB. She was like 3 weeks postpartum, completely delirious, completely psychotic. It was very upsetting for everyone involved. It required intensive inpatient treatment and outpatient treatment
yes.
with medications and the like. It was something. I think we just need to make sure, if we're talking about education, not just the patient, the birthing patient being educated, but their support system. They
Absolutely.
need to know because it's them that might point out and notice if a patient isn't feeling well, not feeling herself after a period of time. That it both postpartum psychosis, which is an emergency,
That is, yes,
and postpartum depression, which is not going to go away on its own. These need to be recognized and reported.
absolutely. Yeah.
Yeah.
And it's good to educate partners too, because they can also experience postpartum depression. But many
Mhm.
people don't even realize that, but they can.
They can.
Just often gets missed because who
Yeah.
wants to admit it? That's the
Right.
hardest thing, even for moms. No one wants to admit it, but
I
we
think
also
that's
try
it.
to
I
get to
think the
that.
numbers are actually higher and a lot of people are
Oh, yeah.
suffering in silence.
Yes, absolutely.
Oh, it's all worth it, man. Let's talk a little bit about babies.
Babies, we love babies.
Yeah,
I
I'll
love
give you the
babies.
reins.
They're
I'll
my
give the
favorite.
reins to my colleague, Professor Lewis.
Babies are my favorite.
Yeah?
Yeah.
Talk to me
I mean,
about
I have
babies.
babies at home. I kind of have to. Love babies.
Yeah, I would hope so. I
So,
would hope so.
yeah, babies. And I brought my number one baby. This was my first baby ever. Um, I've now had to change their name to Teddy. Originally, I named this child Noel. But a lot of people kept calling him Jakipna, you know?
No.
Right. Let me spell it for you. You got a pen and paper?
My gosh.
Well, this is how people were pronouncing my baby's name. So I've now changed my child's name to Teddy. Let's see.
I can say.
JKMNOP, Jakipna. And as a mom, I was kind of getting offended. So I've now
JKMNOP. No L. You okay. JK. No
just
L.
kidding. So yeah, this is baby Teddy. So I love my babies, been taking care of babies for quite some time.
Yeah.
So yeah. You take care of babies?
I do. I do.
Yeah.
It's a privilege. It's an honor and a privilege to take care of them. Love being there when they're first born. Um, tell me what you would do when the baby's
When
first
baby's
born.
first born. So first thing I'm gonna do is make sure that I dry this baby.
Dry the baby.
Dry
They're
the
slimy.
baby.
They're slimy and wet.
They're slimy, they're wet, and just you have to think about thermal regulation. So babies, one, don't sweat, so like they will overheat, and they
Okay.
also lose their like temperature, like will drop pretty quickly.
Uh-huh.
It's not like us, we could walk around like 97 degrees and be fine. Babies, you can't. They lose heat in different ways. And so there's a few ways. You have conduction, which is like if you put them on like something cold, say for example, it's like a cold surface, cold scale when they're first born, that's in the way.
That's conductive heat loss?
Yeah, conductive heat loss. There's convection. So like if there's a cool draft in the air, that might be something you notice too.
Okay.
Radiation is if it's like also like near a cool window or something or near the AC. I usually think like a radiator. Even though a radiator is going to produce heat, think of it as cool air. That's the way to remember. And then evaporation is when they have like moisture on their skin. And so they lose heat that way. So with the amniotic fluid when they're born, right, that's one of the ways that they can lose that heat and drop their temperature. So that's the biggest thing is why I have to dry this baby.
Yeah, I when drying off the baby, I dry the baby off, and that stimulates them too. It really pisses them off, actually, and that's good.
That's good. We want to do that because you have to think about like resuscitation measures as well.
So, I know we do APGARs, but we're not going to wait a whole minute. Tell me about the things we're going to quickly look at to see if they need more than just a drying off.
First thing you should be doing even when you're going in for delivery is you need to know, is this baby going to be term? Is this a full term baby? Greater than 37 weeks.
Ah, that makes sense.
Then you
like, because if it's a preterm baby, they're probably going to have a little trouble.
Yeah. So that's number one. So you can just determine that before baby's even born. Other things you have to wait for when the baby's born, which kind of ties in with your APGARs, is you're looking at their muscle tone. You want good muscle tone, and if they're crying and breathing, and not a weak cry. You want a nice strong,
vigorous cry.
Yep.
And breathing, obviously. Heart rate?
Heart rate, nothing less than 100.
So we want it above 100.
Yeah.
Those things. What about color? I mean, I know that's part of APGAR.
Yeah, color, appearance. Yeah. So actually color, you're looking at it. That's probably why most babies actually don't get a perfect score. APGAR scores
Yeah.
are out of 10, but most babies, like a good score, is really 9. And
9.
you're taking off for color
Color,
because
yeah.
they're going to have acrocyanosis.
So if there's a little cyanotic is probably not needing resuscitation if they're doing all those other
This
things.
means cyanotic, I guess, not in the center. I don't want
Oh
cyanosis in the
gosh, no,
center,
no, no,
no.
no,
But
no.
acrocyanosis of like
A
the
little
hands
bit of
and
the hands and
feet,
feet.
little
All
purple, yeah,
right.
because that can last a few
That doesn't
hours.
mean they need
Breathe in
oxygen or
3 hours.
resuscitation. It's
No,
just
no, it's totally
all
fine.
right.
That's why most babies get a 9.
9.
I've never given a 10. I won't give a 10. That's bad juju.
I've given a 10 at 5 minutes. At 5 minutes. I know, here
I
we are.
wouldn't dare.
I'm not as stingy
Dare.
apparently as but at 5
Not even
minutes.
at 10 minutes if
Oh,
their
here we
half
go.
bars are less than 7 at 1 and
Here
5. Nope.
we go.
Nope.
Anyways, we are going to make sure you know APGARs. I mean, that's like the first thing when we're talking about newborns. Like when I'm signing off to the next shift, I'm going to say, baby Jakipnik, whatever the heck you call him,
Kipnop.
Jakipnop, no
This is
L.
why. No one can
Um,
pronounce my child's name. That's why I changed it to
all right,
Teddy.
baby Teddy, born by C-section today at 10:45 a.m. Apgars, boom, boom. Like that's like the first like descriptor I use on a baby. So it's that important in our world as nurses.
Yeah.
And it's that important for you guys to know. We're gonna set up a scenario and you gotta spit out an Apgar score. And it's not like picking it. We're gonna make you do the math. All right?
Yeah.
We'll make you do the math.
So know all parts of it.
Know all
I
parts
score
of
it.
it.
And
Yeah.
if you get greater than 10,
Eh,
your
and
math is a
you done
little off.
something wrong. All right.
That made
That's
sense.
talk about, bad juju. You give a baby an APGAR score of 11, you're
Overachiever.
overachiever. You're asking way too much. So I mentioned the babies are slimy and wet. Sometimes I see that like the cheesy stuff on them. What's that called?
Vernix.
Vernix
The cream cheese,
caseosa,
right?
cream cheese. It's like, I mean, sometimes some babies are born with like a bagel's worth of cream cheese.
Oh yeah. I could go for a bagel
I'm
right
so
now.
sorry if I've ruined cream cheese or bagels for any of you.
Maybe that's what they'll eat while they study.
Oh, bagels and cream
Listen
cheese.
to us.
Think about it.
And that brings us into our next sponsor, cream cheese.
Philadelphia cream cheese.
You're welcome.
So Vernix is that white cheesy kind of stuff. It's quite a skin emollient, actually. A lot of parents want that vernix to stay and just kind of be absorbed into the skin.
Yeah, and they should. It's good for the baby.
It's good for the baby. It's protective of the skin. Um, it's pretty sticky. And even if they're like overall skin doesn't have it, you're gonna find it in the hiding places, the armpits, the groin,
Yeah.
all that stuff. But it's good stuff, you say.
It is. It's good stuff, and you can get it off when you do the bath. But that's a lot of times why we delay the bath anyway.
Right. So you mentioned heart rate. You want a heart rate above 100.
Above 100.
What
yeah.
about the other vital signs?
Respiratory rate 30 to 60.
30
So
to 60 for
much,
respiratory
yeah,
rate.
much faster than you see in the adult.
Mhm.
And you can't BS that vital sign either. You actually have to assess the baby for a full minute. So
For a full minute. I think that's really important in your clinical setting, because babies tend to breathe, 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 and then like slow it down, even have like short periods of apnea, that sort of thing. So you got to take it all in and really, truly assess for a minute.
yeah, like I've had babies with apneic breaths for like 12 seconds. Anytime I had a baby apneic for 15 seconds, the students totally lost their mind. They're like, the baby stopped breathing. And that's when they started counting respirations, like my baby's not breathing. Yeah, totally normal.
Not
Apneic
good,
breaths are
not good.
normal.
All
So
right. What
we
about,
expect
is
to
that
see
what,
that.
I know with adults, sometimes when they're really not feeling well and like nearing the end, their breathing really slows down. Is that something you're going to see with a baby in terms of like respiratory distress? Are you going to see low breathing rates?
Probably higher. But you
So
also have to,
tachypnea.
yeah, tachypnea, but you got to look at the situation too. Like sometimes when babies are first born, they
Mhm.
might have like these transient, like tachypnea, where their respirations might be in like the 70s. Even I've seen babies up to 80 at like when
Ooh,
they're first born. But again, they're just born, they're getting used to this life
okay.
out here. But if they're in respiratory distress, you're going to see other stuff. You're going to see nasal flaring. You might notice grunting, retractions
Grunting, I have
even.
to say, is not like a sumo wrestle grunt either. It
No.
sounds more like a coo. That's cute, right? It's not.
Um,
It's not. We don't find that cute at all. But
you should record that to be like a ringtone or an
yes,
alarm.
it would definitely wake me up if I heard that. I would definitely like
Yeah,
get up.
get
Right?
startled.
That's newborn grunting.
Maybe halfway through the exam.
Oh yeah,
Just
that's a
to
good idea. You never know what we might pull.
just do
Um,
it.
so if a baby's like really upset,
Yeah.
and crying and the respirations go above 60, it's not necessarily hugely like emergent. But if the baby's like sleeping soundly with a respiration about above 60, that's
That's kind of
concerning.
a red flag.
That's
Yeah.
concerning. Okay. Um, so okay, baby's born, drying him off, do checking all those things. Hopefully not needing resuscitation, but possibly. All
No,
right, what else are we doing for the baby in those first few hours? Do we give him any medicine?
I do.
What do you give him?
I give them erythromycin
I
ointment.
do. Does it sound like
I
I
don't know about
don't?
you do. Well, we work at different places. I've worked at places where you only give meds at 12 hours or when you do the bath, but I do it in the first hour. I give them their erythromycin ointment,
Okay.
inner to outer,
Yeah.
gets rid of any of that nasty bacteria that they might have gotten coming out.
All right.
Give them first dose of hepatitis B as long as the parents are on board, and then
Okay.
vitamin K. You know what vitamin K is?
Well, I know what it is. Why the heck are you giving it to a
To
baby?
prevent bleeding because they don't have their own type of vitamin K just yet, so it kind of holds them over.
Okay, so we were trying to prevent vitamin K deficiency bleeding,
Yes.
VKDB.
Okay, that's very fancy. Like, is that how you explain it to your parents? Because they're probably like, I just had a baby.
Vitamin K, babies don't have it.
Yeah.
Vitamin K, we manufacture our own vitamin K for the proper levels most often by using the normal flora in our guts. Babies' guts are sterile, they don't have any on board. Boom, we give them a little shot. They could be still prone to any sort of vitamin K deficiency and bleeding as a result of that within the first 6 months of life. More so if they didn't get that shot of vitamin K. So it's
Yeah.
pretty important to give at birth.
And you can't do a circumcision if that baby hasn't gotten a vitamin K. Most providers at least won't do a
Now,
circumcision.
interesting, like why would you not give the baby a shot of vitamin K if it could possibly save their life? But you would choose to do a
A
elective procedure like a
circumcision,
actually
yeah.
most people who are refusing vitamin K aren't electing for a circumcision. So it's rarely brought up in my world, but
Not in my
oh really?
all the time. And I'm like, we
Folks
can't do
over
the
there at St. Mary's are a little
circumcision.
bit different.
Can't do the circumcision until we get that vitamin K because the
Right.
biggest thing is bleeding. They're at high risk of bleeding, especially in that first hour.
Okay. That's the other thing. So priority focus or for assessment after circumcision is
Bleeding.
checking for bleeding.
Checking for bleeding.
Gosh, it sounds
And
like
to make
a
sure that it still
postpartum.
looks nice.
Well, we got to make it look nice.
Yeah.
Yeah.
Depends on
After
the
that, it's about infection and all
yeah.
that stuff too. But those first few hours,
Bleeding. High
check
risk
the bleeding,
bleeding.
check the
Yeah.
bleeding. All right.
So that's why you need a vitamin K.
Yeah, I suppose you're right. I suppose you're right.
Yeah.
So talk to me a little bit about we'll just kind of go from top to bottom.
Top to
Talked
bottom.
about the heads for me. We got soft spots and such.
We
What's
got
that all
soft
about?
spots. So when you're assessing a baby, you've already done your vitals. I always say start with vitals, end with vitals, right?
Okay.
Respirations, heart rate,
Smart.
end with
Smart idea.
temperature. I mean, go ahead, make the baby cry. Why not?
Mhm.
Head, you
Head.
want to look at that shape, feel the
Mhm.
fontanelles. Those are the baby's soft spot.
Fontanelle.
Fontanelle,
Mhm.
right? It's a nice word. Maybe someone will name their baby
I think it sounds like a good like 1950s doo-wop
Fontanelle.
female band, singer band. And it's Dr. H and the Fontanelles. No? Anyways, go on.
Yeah, that was a really good reference. So fontanelle, soft spots, they should be soft and flat, not bulging, no speed bump, because that
Mhm.
could be like bleeding or depressed, where the baby is like not hydrated enough. That's
Okay.
concerning. Other things you might notice is their head shape, nice and normal, nice and round, but some babies have molding, nice little cone head, but we don't call it cone head, it's molding. Sometimes you even notice caput or a cephalohematoma. So the caput usually is like a little bit of swelling, fluid is there, and that's going to cross the suture line, where your cephalohematoma is usually on one side, and that could be like bleeding. So I noticed that sometimes if like mom didn't progress in labor, where the baby got stuck, or if they used a vacuum, like a suction tool to kind of get this baby out, sometimes those develop. So that's why you have to assess that head.
So, um, caput is swelling like edema.
Like edema,
Okay.
exactly. There's fluid.
Just across the scalp.
Yeah.
So it's gonna cross the suture line.
Yes, because it
Like
is.
a cap on the top of the head. That's how a cap goes on both sides of the head.
Yes, if you're cool
Well, or if you're French like me, you might wear
on
a
the
little
side, the
beret on the
hematoma,
side.
the
That's a cephalohematoma.
cephalohematoma, and
Cephalohematoma.
little red one on the side.
So sometimes, especially with a baby with like a lot of hair, you can't see because the cephalohematoma is essentially a bruise. The bleeding is like one layer deeper on the scalp, which is seamed off by the skull bones on those suture lines. So because it's one layer deeper, that bleeding is stuck between so it's not going to cross the suture
Yep,
line. Is that what you're
it's
saying?
not gonna cross.
That's the biggest difference between, oh, other than the fact that caput is just edema, cephalohematoma is bleeding. But the way you tell the difference between one and the other is one crossing the suture line, it's caput. If it doesn't cross the suture line, it's probably a cephalohematoma.
So that's why you have to assess that head thoroughly, feel around, give it a nice little scalp massage. And all those things, like, well, they'll go away. You just put a nice hat over the baby's head. No one will notice. Got my hat here. Won't even know that they have a cone
Won't
head.
even
Might
know.
even get them a helmet, whatever you need to.
Now I just want to and it's I don't want to confuse you or anything like that, but cephalohematoma I said is bleeding, bruise. All right, it needs to break down and dissipate. Takes a while to do that. What is the waste product of red blood cells? Just
Billy Rubin.
bilirubin. So
I don't
patient
know
has,
why I'm being tested on this. I already went through OB.
I
I
know, but
passed.
and you should have seen the look of panic. You probably couldn't see it. You could see it, but when I pointed at her and asked that question,
I
she's
wasn't
like, "Oh."
prepared.
Anyways,
What if I
bilirubin,
hit
right?
it?
So a
Oh,
patient, baby with a cephalohematoma might be at a slightly increased risk of jaundice, right? Because increased bilirubin causes jaundice.
yeah.
Hetty,
Which this baby does have a little bit. It's a little bit on the yellow
yeah,
side.
maybe so.
But I'd
Maybe
wait to
from
do some 24-hour testing to maybe see. I usually do it at my place at 24 hours, 28 hours. I guess it depends. I don't know if
28 to
there's any
30.
risk
Yeah. We
factors.
do my hospital every 12 hours.
That's
We
pretty smart.
do TC Billy
That's nice.
because our eyes can fool us.
Yeah.
And some babies, some beautifully dark skinned babies, you can't necessarily see the undertone color. So at 12 hours old, and for every 12 hours that they're in our care, we do a transcutaneous Billy check
Yeah. We do
on
know.
them. What other kind of what other kind of things are we checking for in terms of an assessment? My favorite thing, oh, let's talk about color things, skin things.
Skin things. Oh,
Mm-hmm.
baby's got so many skin things, which are totally normal.
Mm-hmm.
One of my favorite things is Milia, little dots on the nose,
Mm-hmm.
like baby pores. I just tell mom, get a nose strip. No, I'm kidding, I wouldn't do that. But yeah, totally normal for babies. So those look like little white dots. Sometimes you have Lanugo too, little peach fuzz
Peach fuzz
in
hair.
the little foreheads.
Mm-hmm.
You might notice that your Mongolian spot.
Talk to me about those a little bit.
Mongolian spots. A lot of times that looks like almost like a bruise. It's like a bluish purple color. A lot of times we find them on the sacral area on the baby or even like on their thighs. Um, those are very common, especially in like Hispanic, African American populations. Those you definitely want to know. I told my class about this. My son had one,
Mm-hmm.
and they didn't like note it on his physical form. And so when he started daycare at 6 months old, I got a call about how my child had a bruise on his butt.
Mm-hmm.
So if you notice that, make sure you document any
Document,
birthmarks.
document, document. And we talked about it in my class a little bit. It's not because it's physically significant. Like it's
Yeah.
benign, completely benign. And it does
Normal.
it fade? Does he
It a
still
lot
have
of
it?
so my son's is slowly fading. He has
Right.
just a little bit of it. A lot of kids will have this up to they're like 5 years old, but it
Right.
does usually fade in most cases.
So we document it on the admission assessment, not because it's clinically significant, but because it looks like a bruise. And it's often in a place that a kid might get spanked. Well, a newborn baby coming to a pediatric office at 1 month old should not be spanked. I'm not here to talk to you about disciplining your child or anything like that, but a prudent practitioner or nurse sees what looks like a bruise, they're going to go look back at that admission assessment or in a daycare scenario,
Yeah.
look back in that admission assessment, and they're not, if they better see presence of Mongolian spot on that admission assessment.
Yes.
If not, then they're going to think this might be a bruise.
Yeah.
And why the heck
They were ready to call
does a
DCF on me.
newborn, yeah, yeah. And
Right.
you know what? Good for them. That's a good place. And I don't
Yeah.
mean that negative towards you, but a six
So
month old shouldn't have a bruise.
I agree. I agree. It was a birthmark,
Yeah,
okay? Birth
right.
record.
Right.
It's
That's why
on
it's
his
so
birth
important.
admission, okay?
That's why it's so important to look at
Yeah,
that.
so
That's
there's
right.
that. Other things you might notice is like stork bites, especially like on the eyes, a strawberry hemangioma,
Little, it actually looks like a
little,
slice of strawberry
little
skin.
bumpy rays.
Yeah.
Yeah, I see those a lot on the face. Could be anywhere, but
Yeah.
yeah, I see those more on the
Hmm.
face and side. What else can we have?
Any sort of little birthmarks, so not freckles, but little
Oh yeah. Oh,
birthmarks. And
I know. Newborn rash. Erythema toxicum. The worst possible name you could give a newborn rash. Most babies get newborn rash, totally normal, but we're gonna call it erythema toxicum to
it
scare
is
everyone.
it is a scary one. It looks like flea bites, which is also very disturbing to a new parent. It's just the skin's reaction to like the outside world.
Yeah, totally normal.
Yeah.
You see it more too after they get their baths.
Yeah. Right,
Yeah.
because we're adding chemicals to their skin.
Yeah.
We're, rushing. All right.
You shouldn't be adding too many
Well,
chemicals,
no, you
though.
should.
You should be using stuff that are like hypoallergenic
All right.
when you're giving them their bath. No soap in the eyes. I mean, we should talk about baths, right?
Okay, let's
Let's talk about baths. Hypoallergenic, all right. As long as it's baby, it should be good. I usually tell people, right? If
Mhm.
there's baby on it, you're probably good because you want tear-free stuff. You don't really want to be using any soap or shampoo in the eyes and the face
Mhm.
area. Rest of the body, right? Clean to dirty.
Mhm.
Diaper area last and fine.
In like hot soapy water?
No, 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 no. So usually you're doing like a sponge bath because their umbilical cord, that's usually going to take about like 10 days, maybe up to 2 weeks for it to
Mhm.
fall off. And
Okay.
we don't want to get that area wet.
Mm.
So we don't do a bath until that falls off. That's also why we always have parents fold the diaper over the cord because I don't want that.
Over it? Or
Or
so that
I'm
it's exposed to air.
Yes. So
Okay.
pretty much like make sure the cord is out of the diaper because I don't want to get it exposed to any type of urine or
All
anything.
right.
So that's a big thing and we don't want it wet. So it could get infected. We don't want that. And we're watching that. That's why we're also not doing the bath. We're doing the sponge bath, usually like in a little like bassinet on the
Mhm.
bed. Sometimes parents might use the bathtub, but not filling it up with water. I
Mhm.
do say though, whatever you're doing, make sure you're testing the water. That's the biggest thing. Test the water on your forearm, never your hands, because it's always going to seem a little bit cooler.
So this is a sensitive
It's a
spot,
good
right?
area, yeah.
Test it there. If it feels too hot or too cold for here, it's too hot or too cold for the baby. Boop boop.
Just like that.
All right. My beautiful great nephew, every time he took a bath, he pooped. Oh
Oh,
yeah. Anyways, that's neither here
you
nor
must
there. I
have
just thought
changed
he
the
was just
water
so
some nice.
relaxed. It's just so relaxed that he would poop every time. So talk to me a little bit about.
That makes you so happy. Poop makes you really
I
happy.
know he makes me happy.
Oh, okay. I
Yeah.
still think poop makes you happy.
Oh, well, maybe
Okay.
so, maybe so.
Yeah, but it must have changed the color of the water.
Well, it
nice.
wasn't good. Yeah, that part wasn't good. But it was
Cause
like
we,
just at the end when he finally like relaxed and would look down and there'd be poop all in it. Anyways, Talk to me a little bit about newborn poop.
Newborn poop. So the first poop is meconium. That's also, I like that word. I had a patient once named their baby
No, no,
meconium.
no,
Yeah,
no.
yeah. To vouch for it though, she did say like no one ever knows what that is. And I thought back, like when I was in nursing school, that's the first time I heard meconium. So yeah,
Oh,
meconia,
goodness.
little Mecky. Mecky,
Mecky.
yeah, and that's that tarry black stool. That's the
Mhm.
first stool. That's what it's gonna look like. And then it's gonna transition, usually like a brownish green, and then eventually it's gonna be like a yellow seedy color. Especially like breastfeeding babies,
Okay.
got like a golden color to
But
it.
that first poop looks like tar,
Yeah,
and that's
Mecky.
normal. Mecky,
Yeah, totally normal.
my gosh. We talked already about, you said the yellow color. Um, looks like we'll say French's yellow mustard. A
Yeah,
little bit like
that
that.
is a
Again,
yeah.
did I ruin mustard for you?
Well,
Possibly.
just don't ruin ketchup for them.
Oh gosh. Well, you ruined pizza sauce.
Mhm.
So, that's like a breastfeeding poop, right?
Yeah,
We talked about breastfeeding. We talked about the benefits of colostrum and all that stuff. I just want to reiterate that again, and feeding every few hours. Babies don't know. Babies never done it before. So sometimes we have to wake them up to feed them every couple of hours because we want things moving through, right?
yeah.
Despite our efforts and because they've got a lot of extra fluids on board, we would expect them to lose a little bit of weight, up to about 10% of their birth weight. Um, we expect them to regain that weight, like return to their birth weight by like 2 weeks old.
2 weeks. 2 weeks is very big for babies, right? When their cord should fall off, when
It's a
they should be
great
back to
time.
birth.
They're like
Wait, when their stool should have transition for sure. We like that. 2 weeks, two in general, even for feeding time. Feed every 2 to 3 hours of
no,
breastfeeding.
just
Formula
remember
feeding every three
to
to four.
remember to. Um, talk to me a little bit. We talked about the different things. Talk to me a little bit about safety, because safety's huge. Talk to me about safe sleep,
All
because
right.
things have changed since, well, not since my daughter was born, but since my niece was born, even just a few years before. I feel
Yeah.
like it's changed a little bit.
Right.
What is the best way to, um, or the safest way for a baby to sleep?
Yeah. So ABCs of safe sleep. You know your ABCs?
Tell me
You don't know
what
your
that.
ABCs? How did you get to become a
I'm
doctor if
just
you don't know
trying to
your
get you to
alphabet?
explain it to
Okay,
them.
what are your ABCs?
Well, I don't know. I don't
A
know.
B C D E F G. All right.
Noel.
Noel, that's right. Good. Okay. I give you some points for that. So a lot of people are gonna be like airway, breathing, circulation, but ABCs of safe sleep, alone,
A
on
lot
their back,
back.
and in a crib.
Crib.
So pretty much on their back, by themselves, no parent in there, no sibling, by themselves with nothing. No stuffed animal, no blanket, no bulb syringe, no little rattle, no, well, you can't have a pacifier. That's like the only thing. Other than that,
Okay.
by themselves, nothing.
Firm mattress. How about a pillow?
No, no pillow, no
No
blankets.
big fluffy blanket.
No.
None of that. All those
You don't care how nice
bumpers
it
and
looked.
the
I don't care if
fluffy.
great grandma made it. No, nothing.
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 So swaddled up, possibly like in a zip up swaddle
Sure.
thing. And on the firm mattress, no
On their back
stuffies, nothing. On their back,
in the crib or bassinet.
alone in their crib or
Alone.
bassinet, firm
ABCs.
mattress. ABCs. All right, all right. Just want to make sure. I don't know. I feel like these babies, man, they got a lot to learn. New parents have a lot to learn. I feel like our role as nurses is really to monitor what is most often in both mom and baby, or birthing parent, if you will, and newborn, is to monitor the normal healthy process. As nurses, though, we're constantly vigilant and watching for when it goes off track, right? So we have to be ready for it. And oftentimes it's not a screaming loud announcement that there's a complication, especially with a newborn and like respiratory distress and all of that. Right. So we have to watch for it because they're not going to speak up and, use the call bell. By the way, check my circumcision, it's bleeding. Right. So I mean, we can't take our role as nurses for granted. So monitoring for the what if, constantly vigilant for both mom and baby, and teaching them how to safely care for themselves and that baby. And that's really, and bottom line is in a nutshell, our jobs.
Yeah, we do a lot. We assess the babies, we educate the parent,
Mm-hmm.
we do testing.
All those testing,
Testing, there's a lot of stuff we do. Bilirubin, oxygen saturation,
all that.
and the upper extremity, upper right arm,
Upper
right?
right arm,
And any of the
above the
feet.
heart and below the heart.
Yeah, but right arm always.
Always the
And
right
then either of
arm.
the legs.
And
Feet.
either one,
Yeah.
your hospital might say one leg or the other, but it's
Yeah.
really either leg and above the right,
Yeah.
preductal,
And
postductal.
then we do screenings. You do screenings? Do you ever color with the baby?
Yes, I do.
I color with my toddler and my babies. So usually you have to fill in these perfectly. Isn't it crazy? But you got to hold down the baby with their heel and got to hold them at their knee and be like, coloring it in over here perfect. And if I mess up, then the state is like, you did
Yeah,
a
so
terrible job.
we're filling this is filter
Or
paper, and
PKU
we're
and cystic
filling the
fibrosis.
metabolic screening. There's like 35 metabolic disorders we're testing.
Yeah.
Best way to do it is to warm that heel. I did learn recently, somebody said to warm the calf. That actually helps the blood supply. I
Mhm.
just literally learned that about 2, 3 months ago.
Cool.
Yeah.
Warm the heel, even position them a little bit
Yep,
upright for
yep.
gravity. But
Let's use
sometimes if you
gravity.
turn them
Yep.
even on their bellies, but I wouldn't do that, unless you're.
So, warming the heel to try to and lower extremities to get the
Yeah.
blood flow because you need quite a few drops of blood to fill in that metabolic
Now
screening.
the state of Connecticut has.
6, I think, right?
You have 6? I have 9
Well, no, I mean you have your
to
cystic
fill in.
fibrosis and your metabolic screening is 6, right?
Yes, yeah.
Cystic
And
fibrosis.
cystic fibrosis is 3,
2 or
so
3.
9 circles to color in with this baby's
Yeah.
foot.
So it's a lot of blood and that's kind of a stressful thing.
Hearing screen to
Hearing screaming.
gets done.
I gotta say, hearing other than like initially when you gotta get all the gunk out of their ears, but they should have their hearing should be the same as an adult.
No.
We know they can smell, we know they can taste. They prefer the smell of their birthing parent because that's familiar. They prefer the taste of breast milk. And then,
But
so those senses are pretty heightened. I would say that their vision is probably the least acute
yeah,
of the senses.
they're pretty much blind. They literally
You know
see
what?
shadows. I mean, they can't even see mom.
They can't, but you know what?
They make out her
Within,
shape and stuff.
I know, but within 12 inches, I'd say. And guess what? How convenient is that? That's about 12 inches. That's about where they can see. Yes, the contrast
Like
perhaps
blurry
better, but
black
you know
and
what?
white.
That's why we encourage that nice face to face or in face
I think
position
if,
there.
someone can see at 20 feet, they could see at 640. So I'm pretty much putting this baby in a whole other state for them
Wow.
to see what I could see at 20 feet.
Wow.
Amazing. Yeah.
That's ridiculous. Anyways, babies are magical. Our job, quite frankly, even after all these years, is magical as well. And we are happy that you've joined us in
Yeah.
this conversation.
Babies can dance too. They can't dance, but they could
Is
do
that
some
the
cool
dance
stuff.
you guys did? What
No, we did a bubble dance.
bubble
This is just a baby. I'm
honestly,
testing their
you people,
reflexes and there's
there was way too much frivolity going on in the room next door. That's all I gotta say. All right, I appreciate you coming to join us.
thank you.
And
thank you to all of you for joining us today on
and
our
for our
wonderful
sponsors,
Sisters
Bubbles.
podcast. Bubbles, yeah. Bubbles and cream cheese, guys.
There it is.
We will see you next time. Take care.